Over to Dr. Sukumar Barik. Chalo.
Good afternoon, Debika.
Good afternoon, Dada.
ভালো আছিস মনে হয়?
একদম ভালো আছি, একদম ঠিক আছি.
Thank you.
Lovely to see you again.
Nice to see you. I think Subhas is on the way, or maybe has got some work. And greetings from Kolkata. We are a little bit sad because you know that the thing happening here, and that makes us a little sad. But having said that, work goes on. And without delay, if you can start your presentation, and then we can have some question and answer later on. So over to you, Debika.
Can I just ask something? Am I able to see the slides, or am I going to see it from my end?
Pardon?
Am I able to see the presentation, or am I going to see it from my end? Is there a way that the presentation comes up on
The presentation
my screen?
is still not here yet.
Okay.
Is the I can't see the presentation. I can see your face, beautiful background, and
That's my study with the piano in the background.
and there is a piano behind.
So, the tech team, are you sharing my presentation? Because this is on Zoom. I wouldn't know how to do that. If it was Teams, I could manage. So sorry, apologies for that.
They are trying to do that. ওটার এই প্রেজেন্টেশনটা আনা যাবে, প্রেজেন্টেশনটা দেখতে পাবো। দেবিতার প্রেজেন্টেশনটা এখানে দেখা যাচ্ছে না।
বাকিরা দেখতে না পেলে কি করে হবে?
সেটাই তো আমি বুঝছি, বাকিরা না দেখতে পেলে কি করে হবে? আচ্ছা আচ্ছা, ঠিক পাঠাইনি?
হ্যাঁ, পাঠিয়েছি তো।
পাঠিয়েছে?
I have sent it in email and I've sent it through WhatsApp to Joyati.
যদি দেওয়া যায় ভালো। আচ্ছা, 1 সেকেন্ড ওয়েট করে যায়। 1 সেকেন্ড বলেছে কিন্তু দেখছে 1 মিনিট ওয়েট করে যায়, যদি এটাকে দিয়ে দেওয়া যায়।
Whilst we are waiting, obviously it's a very somber atmosphere, not only in Kolkata, but I think there is a global connect to the recent incidents back home. So our hearts are all there, but as you've mentioned, life moves on, and I think moving on is what we all have to do. So with our thoughts in mind, I will go ahead with today's presentation. It is lovely to be a part of this. This is my second time. I've been here last year as well. And it's always better to be there in person to do that interaction. However, I try my best, even if it's a virtual presence. Is there a way I can help in getting the slides across to you if it hasn't reached you?
দেবিকা,
Yeah?
ওটা এসে পৌঁছায়নি কিন্তু। হ্যাঁ, আর একবার সেন্ড করতে হবে।
আমি তো হোয়াটসঅ্যাপে পাঠিয়েছি আর
হোয়াটসঅ্যাপে
ইমেইলেও পাঠিয়েছি।
একটা করে স্লাইড আসছে।
আর ইমেইলে যে পুরোটা পাঠিয়েছি।
আচ্ছা, ইমেলটা আমি চেক করে দেখছি।
আচ্ছা।
You can start.
I can start very much.
And
yeah.
they are trying to put this thing on, so you can start.
Absolutely, I will start. So for those who you know me, I am Debika. I come from Kolkata, and actually my house is in Salt Lake, so I'm your local person. But for the last many years, let's say, I've been in Manchester. So greetings from Manchester. I'm an obs and gynae consultant in Manchester. So today I will sort of talk to you about women's health, diabetes and women's health. So it's a bit of a broad spectrum, and I will try to keep the obstetric bit out. I can see myself now on a bigger forum. Are you able to see the slides? Does that mean that the slides are on?
Carry on, no problem.
Okay.
Slides,
so what is going to happen is we are going to see from a gynecological aspect rather than the obstetric aspect of things. Now, with an ever increasing population of young women living with diabetes nowadays, I think as clinicians, we need to be aware and keep ourselves equipped for the challenges of reproductive health during the lifespan. And what I'm going to do for the purpose of this talk is sort of divide my talk into age groups. I've heard a previous speaker talk about childhood, so I'll start off somewhere around the adolescent and teenage times, then move on to the midlife situation, reproductive years coming forward, and go ahead from there. Okay, now what I want to reiterate is I'm not a diabetes expert at all. So you are the experts. I'm going to sort of brainstorm you with things from a gynecological aspect, and correct me if I am wrong. It's a discussion, and as you know, we are all part of a multidisciplinary team, so we all have our roles in there when it comes to talking through. Is there the slide behind you, Dada? Is there something behind you? Can we?
Trying to, but you carry on. They are trying to put the slides on, but you
Okay,
can
I'll
carry
on. It's just because I had a few cases to share with you.
I
So I
think
was
it's
thinking and
coming.
hoping if it comes
It's
across,
coming
I'll
now.
wait for that. Otherwise, I'll continue to
It's
speak.
come now.
It's come?
It's come. Your photograph is there, but the slides, please. All presentation আসছে না ওর সাইডটা তো এসছিল সাইডে এসছিল তো এক্ষুনি এসছিল না ওটা পরে
Does it help if I send it to you again? Oh, there it is.
I can see
Thank
that.
you so much. Yeah, thank you.
I can see that.
Oh, that's me flashing on your screen.
And the next one. Next one. Next one koro. Next one koro. That's right. It's there. Carry on.
Okay. Okay.
Yeah.
So if we go to the slide number 3, where we are seeing that how I'm going to talk through. So we are sort of dividing it into the adolescent and teen, and then we're moving on to the reproductive age, and we go to midlife and beyond. Okay. Can we move on to slide number 4, please? Yeah. Okay. So what is important is that this is a very common scenario. This is what we call the trouble teens. When suppose a 17-year-old girl comes to you, presents to you with unwanted facial and body hair. She has had this since the start of her menarche, and she's tried many things to do, and it's not nice for a teenager to be having facial hair, hirsutism. It's making her feel down. She's lost her self-esteem. She's withdrawn. She's gained weight recently. And to top it all, she's having some menstrual irregularities. So I'm sure this is a no-brainer, and you know what it is. And what do you think it is? Yeah? Yeah? I'm sure you have an answer by now. Yeah? Yeah? So if we go on to the next slide, are we on the next slide now? Because I can't see if the slides are moving.
Yeah, PCO, fine.
Yeah, so we have now what we call a condition which is known as the polycystic ovarian syndrome. It's a very, very common condition, actually, and it is one of the most common endocrine disorders in women, of the reproductive age group globally. And the common link with diabetes type 2 and PCOS is probably insulin resistance and weight gain. So that's a common link. And we all know that the best thing to recommend to this young population is lifestyle changes, because lifestyle changes is one thing which can go a long way in making them feel not only better, but help them with their condition. It is not only the menstrual irregularities that they come with, they also have in the thought of their mind, and in their mind they are thinking that in a couple of years' time, if I was to start a family, is there going to be a problem? So yes, there is a link with subfertility in the future. And also, when you embark onto a pregnancy, that can have its own problems as well, leading to conditions like acquiring the gestational diabetes in the pregnancy. So this is the actual time to grab them, give them the information that they need and take it from there. So there is a comparison if you see on the right side. I'm not sure whether you can see it. Are you able to see it? I can see your hands up. Is there a problem?
You just have to mention next slide, please. That will be fine. So now they have moved to contraception.
Okay, okay. So that's all right. If they've moved to contraception, that is not a problem. But I think you have skipped a few slides. Just go to the next one. Yeah, yeah. Stay there for a minute. So if you see on the right side, what it's trying to show you is the relationship about the PCOS and type 2 diabetes in the future with respect to weight. Okay, so compared to people who've got a normal weight and people who are overweight or obese, the association of increased possibility of type 2 diabetes and PCOS is more with the obese population. You can move on to the next one, please. So impact of diabetes, actually, historically, when we didn't have such advanced treatment, the spectrum was huge in the reproductive health group. So it could be delayed menarche, it could be menstrual abnormalities, it could be subfertility and adverse pregnancy outcomes. But with the intensifying and excellent control through medication, especially with insulin therapy, improved metabolic controls, these problems have definitely declined. But still there, because there is that metabolic stress of TID, which is a multifaceted challenge in this age group. The next slide, please. Okay, so this is what we have got from difficulty of sexual reproductive health, and this sort of categorizes the role of contraception and what we can give. So you can see on the upper right, those are the categories which is used in UK, and also WHO has got a similar category to use, and which says that the categories specify when it is safe and when it is not safe to use them. There is a huge role of contraception in the young women when it comes to diabetes. Firstly, it can be used to stabilize the disease. So that's the preconceptional one, to get them to the optimal help, get them to the right medication before they embark on a fertility journey. It is also used as a treatment for conditions like PCOS, and it can just be used for people who are not wanting to have a baby at this time. So what contraception can be used and what is the safest to be used sort of is summarized in the table. So most of the times we're able to offer them good contraception, and especially for the PCOS ones, we try to give them a combination of estrogen and progesterone with the low dose estrogen and the newer generation progesterones for them to counteract the androgenic effects. Next one, please. Going forward, as they're moving along in their age, it is surprising to know that sexual health, which unfortunately is still a bit of a hush-hush topic to discuss in certain countries and also in India, it is actually a big problem. When I was going through some literature, I was astounded to find that more than 1 in 4 women with type 1 diabetes have sexual problems. And whatever we say, this is a very important part of an individual's life. So we have to treat them accordingly. Recurrent UTIs, vaginal dryness, thrush, we all know are more common in this category of young population. There was a research conducted which sort of tried to evaluate the quality of life in these young population, and the common theme was that there's hopelessness. They are feeling they've lost their self-esteem. They don't know when they're sweating it is a hypo or is it something else. So it's a lot of important role for counseling. Catch this population, control their sugar levels, and help them through their journey in the reproductive age group. The next one, please. So we're moving on now to a slightly older age group. This is, for instance, a 65-year-old known diabetic, and she's been known diabetic for the last 10 years. She also has hypertension and dyslipidemia. She's got a BMI of 42. She initially had a small amount of vaginal bleeding about a month ago, and carrying on with life, she sort of ignored it. And then, can we go on to the next one? I think we're going back. We go on to the next slide. Where are we? Are we on the slide which is showing the sinister triad?
It stopped in the contraception bit, but you carry on. I can hear that 65-year-old, and you just carry on because it's not moving. It's stuck on the contraception on. But you can move on. They are trying to.
Okay, if we can go to the one before that, that would be helpful. Yes, that's good. So that's where we are. So so this is where we were. That she came back to bleeding, and this time it's moderate. Any clue as to what this can be? Any idea?
It's not
I
being
know
shown
you know.
here.
Anybody from the audience? Anybody? Any idea as to what this is? So it's 65-year-old with hypertension, diabetes, bleeding. It's like a postmenopausal bleeding situation. Yeah. So we
Yeah.
are thinking sinister. We are thinking cancer. So if it is possible to go to the next slide, which you just showed a few minutes ago. Yeah. Diabetes and gynecological cancer. So there is a link. The commonest one is with endometrial carcinoma. There is some evidence to show that there is actually a link with other type of cancers, including ovarian. But the most common one would be the endometrial cancer, who presents on a typical overweight, hypertensive, diabetic person. It's known as the corpus cancer syndrome. If we go to the next slide, please. It is very, very important to identify this. So postmenopausal bleeding can be for many, many causes. It can be for benign causes, certain things like polyps, or it can be the sinister ones. So identifying this group, giving them or channelizing them to the quick investigation. So in UK, we have a very fast track referral service because the GPs send to us. So if women going to your care, even going to the general side of consultations, like to the medical specialists, if they ever mention a postmenopausal bleeding, please fast track them to a gynecologist so that they get channelized to get the right investigations, including scans, they get hysteroscopies, they get biopsies, and obviously they need treatment. Now, the most important thing is it's not only diagnosis, it's a holistic care, because it doesn't end with identifying what they're happening. It then moves on to the care. And the care, if they land up like surgery, it will come with a lot of input from the diabetologists, because you need to optimize their health pre-surgery, during surgery, and post-surgery. And things like chemotherapy, if they need, for instance, later on, extensive vomiting, their blood sugars, their blood glucose control will go absolutely through the roof. So a whole lot of input is needed from diabetic nurses, diabetic specialists, and everybody who can get together. The next one, please. Okay, so we've briefly touched upon this, and I was going through some statistics to say that, obviously endometrial cancer is very much prevalent in the Western developed country. And it seems like with change of our lifestyle, with changes of the way we are, putting on weight, obesity, there seems to be a trend of increase of this in India as well, and especially in the urban areas. Next one, please. Now, with people like us, when we think that our kids have gone to college, we are not fighting with our spouses too much, we've got used to them, and we think our life starts at 50, and that's when our life's sat-nav takes us to the menopause lane. So this is a time when people with diabetes wonder, and because menopause is a Pandora's box, there are lots of things which are happening to the body, which is not pleasant, and sometimes you need help. So we all know at this time the estrogen levels are falling, and a lot of us feel a lot of changes. So what happens then? What do we do? Is the HRT an option? Do we take it? Is my sweating a hot flush? Is it a hypo? These are sort of things which are gray zones, and it needs clarity. So we need to ask these questions. We need to talk about these things and help. The next one, please. So as I was saying, these are the sort of questions which come to our mind. The most important takeaway message from this bit is that if you need HRT, you need HRT. So HRT is possible in many, many different routes, in many forms, and we have to then just find out what is the right route and what is the right form which will help the person. The next slide, please. So hormone replacement therapy is needed for menopausal women, and unfortunately, the menopause time is obesogenic, so you tend to put on weight. So it is a challenge to provide menopause care for obese and diabetic women. What is important to know that now there is like a cafeteria choice, as we used to say for contraception before, there is a cafeteria choice of HRT now. So people who are overweight, people who are worried about what is going to happen, they need proper counseling. There is a role of transdermal route. There are roles of sprays. There are roles of pumps. So those are the ones which can be offered. And HRT, if you feel that anybody who's coming to your practice and querying about things, again, guide them and send them to the right channel, because there is a lot of controversy about HRT. And I think, you know, in our lifetimes, there will be no solution and the controversy challenges go on. But if they need it, we have to offer them in the right way. Next one, please. That's where I have gathered my references from. And if I move on to the next one, as I say always, that life doesn't have to be perfect, but it is a wonderful life. With challenges, we can overcome diabetes in women. Thank you. I'll be ready for any questions. Sorry for a little bit of mess up in the slides at the start, but I hope you've sort of followed what we've said.
Wonderful presentation, Debika.
Thank you.
I think you wonderfully divided into the age group and the adolescent, the reproductive age group, and the menopausal age group.
And I want to, at this point, mention to the audience in front of you, many years ago, when I was in India, Dada, Dr. Barik, was an expert in polycystic ovaries and gave us a lot of talk on it. So my heartbeat was going a bit higher trying to talk about this topic in front of you.
Thank you, Debika. I think my search for PCOS still going on. One of the students is doing a PhD under me now on PCOS. You'll be glad to know that. But there are lots of unanswered questions still now.
Absolutely.
In PCOS. We do understand something. We understand a lot of things are not known yet. But yes, we know that the hyperinsulinemia is a factor. There is unanswered question that whether all PCOS patients will need any insulin sensitizer. What's your opinion about that? Because in India, there are a lot of people, whenever they diagnose, actually loosely
Metformin is standard. Yeah, and I'm absolutely with you. So again, the norm shouldn't be, metformin is not for everybody. It should be given to those who need them. And metformin actually is a magic drug when it comes to the reproductive age group. It has got lots of good things in it, but what we try to do in UK, make it a bit more standardized. So it is given to those who are, say, for instance, planning a family or wanting to start. So those are the ones who are given. Some fertility centers are offering metformin as a preparation to a pregnancy. And those are the ones who also would need some sort of an ovulating inducing agent. So I think it again needs a lot of counseling. It should not be like a paracetamol, is what I'm trying to think.
Absolutely. I think this is what we practice today, but actually a huge number of people in India prescribe metformin. Not only that, there is a huge surge in the prescription of myoinositol, new kit, and that has just bombarded the market like anything. What's your opinion about that, the myoinositol? I know it is not very much favored in UK, but in India...
No, I don't think we use it here much. My experience with this is very limited. In fact, I would love you to talk about it, and I would like to know about it. The only other thing that I want to say is, I mean, I didn't mention here, there is something called Mozambique, and there are certain new injections which people are using to lose weight. So they are anti-diabetic medications, and people are now trying to, they're trying getting it over the counter to lose weight. Now, I personally feel that that shouldn't be the first line. The reason why, the minute they use it for some time, they're not only getting the benefits, if there are, they're getting the adverse effects as well. And the minute they stop it, there is like a rebound gain in weight. And, for those of you who know how UK works, when we are doing our on-calls on the labor ward, the midwives are always giving us the information as to how they're going to slim down for their parties. And that is where we get the information as to how anti-diabetic medication is being used for weight loss. So that is our new way of gaining knowledge. But to be coming back again, I don't think that should be a standard practice.
You are right. I think it's an extension of the anti-obesity medications, which is causing the problem, which is being bombarded. And there are many non-gynecologists are initially trying that one. But your warning is very valid that there is no standardized treatment in obesity which is recommending that. That's absolutely fine. And I'm very delighted to know that when you are talking about postmenopausal bleeding, the quick in and out, or you have to have a quick referral is mandatory. Although we know that not all postmenopausal bleeding has got endometrial hyperplasia or carcinoma, but it's a subsection. At least 5 to 10% or 3 to 5% will have endometrial carcinoma. That's a very nice thing you have mentioned. And I'm very delighted to see the slide that life begins after 50. Some time ago, we used to say that life begins at 40. So
no. Next time I will present, life will probably begin at 60.
Correct.
Because the parameter is changing with my age.
It always been the case. The speaker depends on the speaker. Where the speaker is. If the speaker is 45, the life begins at 40. If the speaker is 51, life begins at 50. And the speaker begins, age is 61, then life begins at 60. But actually speaking...
Thank you, absolutely. No, actually, our longevity has changed. Things have moved on. আগেকার দিনের মতো 40 পেরোলেই তো আর 40 হচ্ছে না, সেই জন্য এখন অনেক এগিয়ে গেছি আমরা, and a lot of our good life is spent in the menopausal time of our life. So we have to consider, taking care of ourselves.
Absolutely. I think there is a good and very productive life is there, and it begins from that time onwards. So why not to remain fit? Why not to remain? Absolutely. I think we are delighted to listen to this. And is there any question from the floor, or otherwise we'll be thanking you again and thanking you profoundly. And I think from here we end the session at this moment. And I think there is a jacket waiting for you. Whenever you come here, there is a memento waiting for you. There is a jacket waiting for you.
I will be visiting in November, so I will be getting in touch with the team.
So please contact Jayati.
Will do.
Please.
Thank you so much. And have a fantastic rest of your conference. Thank you.
Thank you very much indeed. Thank you. Thank you very much.